it indistinct. So this is the same patient, normal on the left and with interstitial edema on the right. The vessels look larger and they're ill-defined. You can't pick one vessel out over the other. This is called perihilar edema. If we go a little further on, we start to see some more lines and different things happen. We get curly B lines, which are these perpendicular lines, and this is due to fluid in the intralobular septa of the lung. We get peribronchial cuffing, which you can see in the hilar regions, and we get fluid in the fissures as well. Now all the hyla are big here, the vessels are ill-defined and indistinct. This is interstitial pulmonary edema. Again, this is a normal on the left and an abnormal on the right, same patient with interstitial pulmonary edema. Way more lines, sort of ground glass haziness, hyla are bigger, and the vessels are ill-defined. We go to the lateral view and we see some similar changes, normal on the left, abnormal on the right. We've got thickening of the fissures here, which you can see, and the hyla look bigger and they're smudged, they're ill-defined. Sometimes also in the lateral view we have small bilateral effusions when we have interstitial edema. Again, great films that show you the changes of interstitial edema. Peribronchial cuffing, curly B lines, thickening of the fissures, small bilateral effusions, increased interstitial markings, hyla are enlarged and indistinct. And this is just a blow-up of the curly B lines, which are these perpendicular lines that where fluid tracks into the lung from the subpleural space. Curly B lines again on the CAT scan, which just shows you these perpendicular lines as they come in. Now once interstitial edema develops to a certain degree, there's no more space in the peribronchial interstitial and subpleural space for the fluid to go. So it flows into the air spaces and then we get airspace edema. So here's a picture of airspace edema on your right. You can see that there's peribronchial cuffing and there's fluid in the fissures and everything else the same as before, but now we have fluid inside the airspace, so this is going to lead to airspace consolidation. And if the patient is upright, this is what it's going to look like. Upper lobes are going to be fairly normal in appearance, but there's bilateral lower lobe consolidation, small bilateral effusions. So all of the changes are in the bases if the patient is upright. If the patient is supine, okay, like this patient who's in ICU, you can see that most of the changes are going to be in the perihilar region. So on your left, there's some mild interstitial edema. On your right, we have consolidation around both lungs. The lower lobes and upper lobes are less involved, but the changes are symmetrical and bilateral. Finally, if it progresses too far, we're going to get severe airspace disease, which looks like this. This is a solid lung on both sides, and you can see the branching bronchi into the airspace disease, and this is the air bronchogram we talked about. So, in airspace edema, the consolidation is bilateral, it's symmetrical, and the consolidation is gravity dependent. Now, if you're looking at serial X-rays from one day to the next, or even 1 hour to the next, the consolidation that's due to edema is going to change. And it changes depending on the position of the patient and the degree of fluid overload. So if you have consolidation that is changing from hour to hour, this is pulmonary edema. Okay, so this is our next case. And this is a patient who comes in and is a little short of breath. What do you think of these findings? Well, the diaphragms are flat, aren't they? Can you see that? They're both flat bilaterally, and if you look at the right hemidiaphragm, there are these little slips that appear off the diaphragm, and these are diaphragmatic slips, and they form, and you see them because of hyperinflation. We also see there's an increase in the AP diameter of the chest, and we see there's an increase in the retrosternal space. Both of the lungs appear black, which is another feature of emphysema. So this patient has emphysema. Some of the characteristics are increased lung volume, which leads to flattened diaphragms, increased retrosternal airspace, and a barrel chest. The vessels in these patients appear very small in the lungs, and there's a small narrow cardiac silhouette, and these are all features of chronic obstructive lung disease and emphysema. Here's just a CT scan example of the same thing, which shows you these holes in the lung. Some of these are bullae and other are areas of emphysema. Now the last topic I'm going to touch on is the radiographic patterns of pneumonia that we see in the lung. Now basically there are three different patterns of infection of the lung. There's a lobar pneumonia pattern, there's a bronchopneumonia pattern, and an interstitial pneumonia pattern. And all three of them are distinct, and all three of them are caused by different agents. So it's something that you want to remember when you're looking at a chest X-ray. Lobar pneumonias usually involve one single area of a lobar lung. The rest of the lung is normal. In this particular case, there's a right lower lobe pneumonia. There's an area of consolidation there. There's an air bronchogram there. We don't see the silhouette sign in this particular instance. Lobar pneumonias are usually caused by a blood-borne pathogen. And that pathogen goes to one area of the lung and spreads from there. It's almost always unilateral, and the commonest pathogen to cause a lobar pneumonia is a strep pneumonia. Now, lobar pneumonias are an irritation of the lung parenchyma that is associated with an outpouring of fluid. And the reason we get airspace disease is not because of pus in the air spaces, but because of fluid. So lobar pneumonias tend to come on quickly, and when they leave, they resolve completely because most of the reaction is fluid in the air spaces. Here's another example. Here we have consolidation in the left lower lobe. And again, we go to the lateral view, go down, it gets white at the bottom. We've lost the left hemidiaphragm centrally. This is a left lower lobe pneumonia. And this is another characteristic for lobar pneumonia is the air bronchogram, as we already said. Here on the CT scan, we can see a large, predominantly unilateral area of consolidation, solid lung, no volume loss, and an air bronchogram. This is a lobar pneumonia. Now, on the other hand, bronchopneumonias are quite a bit different. Bronchopneumonias are caused by an inhaled pathogen, and if you just remember that much, you can remember what the distribution is going to be like. Of course, if the pathogen is inhaled, the changes are going to be bilateral. Okay, they're going to be asymmetrical because more germs are going to go to one area than another, and they're going to be scattered throughout both lungs. The lower lobes are going to be predominantly involved because when we inhale, most of the air goes to the lower lobe areas. There's peribronchial cuffing seen centrally because these pathogens attack the bronchial wall. They cause fibrosis in some of the walls, they cause inflammation in the bronchial wall, and this leads to areas of mucus plugging in the bronchus and distal atelectasis in the lung. But what you look for on a chest X-ray is bilateral patchy airspace consolidation. Now, the commonest pathogen for a bronchopneumonia is Staph aureus. Because the inflammation is in the bronchial tree, it's much harder to heal, and often these pneumonias heal with scarring. Not like the lobar pneumonias, which tend to clear up completely. These pneumonias are usually more serious. Here again, we can see a bronchopneumonia. You've got consolidation involving almost all of the right lower lobe, taking out the middle lobe area as well. Centrally involving the left hemidiaphragm, the apex of the heart is gone, and all of these patchy white areas all over, and this is a bronchopneumonia. If you look centrally, you can see one bronchus which is thickened and coarsened centrally. This is what a bronchopneumonia looks like on CT scan. Bilateral patchy airspace consolidation. You can see that one area in the right middle lobe where there's actually an air bronchogram. Can you see the peribronchial cuffing? All the bronchi are really thickened here. Now the third kind of pneumonia you're going to want to recognize is an interstitial pneumonia. These pneumonias involve the interstitial spaces, the parenchymal interstitial space, and not the airways. Gives you a ground glass appearance to both lungs. It's bilateral and symmetrical in most cases, and sometimes there's a halo or a cortex of normal lung. Here you can see black aerated lung above the diaphragm on each side and around the heart. This type of appearance is fairly typical of an interstitial pneumonia. These areas will be spared where the central core is involved. Also see that there's no silhouetting. There's no silhouetting of any part in the early interstitial pneumonia. There's maybe a little bit of an air bronchogram, but not very much. Now, if severe, the interstitial pneumonia can go on to airspace disease. These are called atypical pneumonias, and the commonest pathogens are PCP, mycoplasma, viruses, and different kinds of pathogens that are atypical. Here we have a picture of a normal with a very early interstitial pneumonia. Sometimes it's extremely difficult for the clinician or for the emergency doc to tell whether there's interstitial disease or not. Often it's very helpful to have a previous film for comparison. Here we see some very mild interstitial changes in. Later on, this is what it looks like. Okay, so again you have the bilateral, symmetrical, ground glass. You spare the periphery here, no silhouette sign. This is an interstitial pneumonia. And on the CT scan, just looks like this. It looks like ground glass everywhere.